All right, so welcome to the Gait lecture. So one of the things that I always want to start with before we just jump into the actual gait presentation is actually what does normal gait look like? Because if we can have a good understanding of what normal gait looks like, then that will help you with the pathologies that may present or that will present later and help you to really understand what is occurring um, to these individuals that is causing their different impairments. So the first thing that we're going to review is this actual picture that is on your screen. So if we look at this picture um, and we see, excuse me, we see that obviously we have the gait cycle is broken up into stance versus swing. Okay, so how I tell individuals to study gait is you want to go through each actual, not only phase, but each actual step within the phase. And then in terms of being able to name what motion is occurring at each joint, what muscle is acting concentrically. Okay. So for example, and we're going to go through all of these actually. So during stand phase, the first thing you're going to start off with is heel strike. So at the hip is in flexion, the knee is in slight flexion, moving towards extension. So at this point, you're moving towards extension, and then the ankle is in dorsiflexion. So the concentric movers during this time are the iliopsoas at the hip. Quadriceps are becoming active at the knee to develop some knee extension. And then your anterior tibialis is going to be the prime mover at the ankle for dorsiflexion. We move to loading response. Okay, so in loading response, again, the hip is in flexion, the knee is again moving towards extension. It hasn't all the way gotten there yet. And then the ankle is in a point of dorsiflexion. If you look at this picture, yes, the ankle looks pretty flat, but in relation to where this individual's body is. So if we look at their body, right, their ankle, their body, their trunk is posterior to their ankle, which is going to lend itself to a dorsiflexion moment. Okay. So at this point, you're still in dorsiflexion at the ankle, right? So again, if we go back down the chain, your hip is in flexion. So iliopsoas is active. The knee again is moving towards extension, so your quadriceps are active, and then your ankle is in dorsiflexion. Although it has slowed down, but it is still in dorsiflexion, and thus your anterior tibialis is the prime mover. If we move towards the mid stance time, so mid stance is really categorized as there are two times within the gait cycle where basically the trunk is directly over the hip and over the entire lower extremity. And mid stance is one of those times. So during mid stance, you have the hip that's in a pretty neutral position, and we'll talk more about that in just a second. The knee is in extension, and then at this point, the ankle is in a neutral position. So we don't really have a prime mover at this point. So the thing that we want to talk about is the hip. So the prime activated muscle is your glute medius is going to be active on this at this time. So the role of the glute medius is to essentially allow the pelvis to remain level. If you have any type of deficit, or they mention, and we'll talk about this in a moment in a little bit, about the pelvis being uneven, is typically due to a glute medius weakness. Again, the hip is an extension, so we're going to see your quadriceps femoris is going to be active. And at this point, the ankle is not in a neutral position, so it's more of a stabilization at this point. You do not need to pay attention to the amount of flexion, the amount of extension that should be occurring as the NPTE has moved away from that, but you just need to really understand what motion is occurring, what muscles are active, so that you can accurately be able to assess the actual deficits that are occurring. Okay, as we continue to move along, we look at terminal stance. So in terminal stance, we have the hip is an extension, the knee is an extension, and you have now moved into plantar flexion of the actual ankle. So again, if we're going through muscles, hip, your glute maximus is activated. Again, your quadriceps femoris is activated at the knee, And then now you have your plantar flexor, so you can have your tibialis posterior. Gastroc is going to be active at this point. Key thing about pre-swing is I want you to keep this in mind. So in this, it's called pre-swing, and also may be called toe off. In pre-swing, you still have a point of contact with the floor. So this is technically still stance phase. So when you think about pre-swing, toe off, it essentially is just telling you you are preparing to go into swing, but you still have a point of contact with the floor, which we'll talk about in just a moment. So again, your hip at this point is starting to move towards flexion. Again, okay? So your hip is moving towards flexion. Your knee is now flexed. Your ankle is plantar flexed, and your great toe is activated. Okay, so your great toe extensor, so your extensor hallucis longus is now activated. So again, if we talk about the muscles that are active at the hip, iliopsoas is again beginning to engage. Hamstrings are active at the knee, and then at the ankle you have your posterior tibialis gastroc, and then you have your extensor hallucis longus, your great toe extensor that's also active at this point. And then swing phase, you have toe off, mid swing, terminal swing. Some will say initial swing, mid swing, terminal swing, but know that terminology is the same. So in toe off, the actual toe is removed from the floor, right? So hip is in flexion, knee is in flexion, and again, ankle right now is still is going to actually be in. Um, you're actually going to be moving towards dorsiflexion at this point. So this picture doesn't necessarily depict it, but you're actually moving towards dorsiflexion. So I want you to think about this. The reason that you're moving towards dorsiflexion is because you want to be able to effectively clear the extremity. If my foot during swing phase essentially was in plantar flexion, then that would make my toe, that's when individuals typically start to have toe drag, right? The goal behind swing phase is you essentially want to make this limb shorter than the other side so that you effectively can clear it, right? So because of this, you're typically going to be in hip flexion, knee flexion, and ankle dorsiflexion. So again, some of the same muscles that we talked about previously in terms of your iliopsoas is going to be active at the hip, hamstrings at the knee, and anterior tibialis at the ankle. Mid swing, again, you're going to be activating the same muscles. So you're going to have hip flexors that are going to be active because you're in hip flexion. So iliopsoas will be active at the hip. You still have your hamstrings active because you are still in knee flexion. And then you're still going to be in ankle dorsiflexion, right? So your anterior tibialis is going to be active at this point. Moving up to terminal swing. So terminal swing, right? Your foot is still in the air. You're going to be in hip flexion. Your knee is moving towards extension, so your quadricep femoris is going to be active at the knee, and then your ankle is still going to be in dorsiflexion, so anterior tibialis is going to be active. My challenge to you when you are reviewing this information is spending time with this actual picture to go through each one of those step by step. The reason being is that the keys within the question that you will see are typically going to be about if this individual, what phase of the gait they are in, and is also going to be looking at what are their deficits, their prime movers, those type of things. So you want to make sure that you're paying attention um, to that information as it's presented. Okay. So that is the information for how you should look at the actual gait cycle. If you notice, there's a lot of overlap that's occurring. So I want you to understand that you will typically see quite a bit of similarities between each of these phases. So as you heard, I went over hip flexion, knee flexion, and anterior tib was primarily involved in the majority of this. So we talk about hip flexion, knee flexion, right? And then anterior tibialis activation is the primary thing that's happening during swing. You have some outliers where the glute maximus and medius are located. So what I would suggest for you to do is to group things that are similar together, right? So swing starting and swing phase makes more sense for you in terms of understanding the information because the foot is off the ground and then it comes in contact. Then start there. or you can go back and start at stance phase. So how you group this information is imperative, but the biggest thing is that you want to spend some time writing this out, um, writing out a chart, those type of things of activated muscles, actual movement that's occurring at each one of these joints. So we go and we review the actual Gait lecture that was given. Okay, so um, obviously there are some objectives that are present. What I do want you to take in consideration is that the beginning of this lecture is a lot of definitions, right? So not necessarily things that are going to be we're going to necessarily review, but I'm going to highlight some things that you should review on your own, and then we're going to just kind of move through the remainder of the lecture so that you have a good understanding of this content, so that you will be able to review it effectively on your own. Okay. So some things that you want to take in consideration, right? We just looked at the picture of a gait cycle. And so with the gait cycle, just knowing that 60% is spin and stance, which we saw that from, from initial contact or heel contact all the way to when the individual was in pre-swing. All of that was considered stance phase. And then you have 40% of the cycle, which is in swing. Some for definition purposes, typically a good base width is about 2 feet apart. So that's the width of the individual shoulders, right? Typically, if an individual has a very narrow or a wider base of support, it's typically indicative of a pathology, which we'll discuss at a later time. I do want to talk about step length. So step length is the distance between two consecutive points on the opposite feet. So step length is going to be measured from left to right foot, right? So keep that in mind because questions will ask you step length, right? Versus stride length. So step length is right versus left, right? The distance between when I place my right foot on the ground to when I place my left foot on the ground. Whereas stride length is the distance from when I just place the right foot. Every time I pick my right foot up and I place on the ground, what's the distance from its last point? So again, step length is right to left, right? The distance between the 2 feet, and then your stride length is just looking at one side. You have cadence, which is going to be the steps per minute. And then you have a gait speed, which you may see in some questions, but you will not see them ask anything specific around you having to calculate cadence or gait speed, right? So if you notice that I kind of interchange the terminology that you could see um, on the exam. So there's a traditional and then there's a ranchos los amigos terminology. The terminology that was on that presentation was a mix of the two. But just know because the reason why I selected that actual picture is that in transparency they go between traditional and ranchos los amigos, right? So knowing that they are the same, so heel strike equals initial contact, foot flat equals loading response, mid stance, heel off is terminal stance, toe off is pre-swing. That terminology remains the same, right? So these next couple slides will go through what are the intricacies of each one of them. What I want you to really take away from these next couple slides is not so much of the definition, it is going back to what that picture was that was just shown, right? What heel strike looks like, what is actually occurring, what's actually occurring at terminal stance or heel off, what is actually occurring at each one of these phases, as opposed to the actual definitions, because the definitions don't provide, I feel like, any additional clarity, but students like to have them, so I have them on the screen. Okay. So you have your heel strike. So again, you have your traditional language at the top, your ranchos los amigos language at the bottom. Again, heel strike is just when the heel becomes in contact with the ground. Initial contact, they expand upon that definition just to say this is the beginning of stance phase, right? Foot flat and loading response. Again, this is basically when the entire foot is coming in contact with the floor. So initially, we know it at initial contact, right? That the heel was just in contact. Now we have the entire foot that's in contact with the floor, and so this is allowing basically the opportunity for the body to start to move over this foot. Mid stance, same terminology for both ranchos as well as traditional language. So this is the actual time when the body passes over the foot, right? So this is when your glute medius is activated because you're trying to keep the pelvis level. Okay. Um, for the ranchos definitions, it gets pretty extensive. It goes from say portion of the single limb support stance phase, beginning with the contralateral extremity leaves the ground and ends when the body is directed over the supporting limb. Again, just remember that this is during stance phase. So this is when the body, when the hip is, the trunk, hip, knee, and ankle are in direct alignment with each other, is how I really want you to remember mid stance. Heel off, it says is the point following mid stance. So basically, as indicated, it's when the heel is raised. So this is the time where have moved from neutrality of the ankle to actually your plantar flexors are starting to be activated at this time. So another way in which you can review this information is when you are looking at um, the different phases and reviewing your notes, you can actually use this as an opportunity to go back to, okay, when I looked at the picture versus what I see now, stance phase, okay, at this point, it heel off, the hip is in extension, the knee is in extension, and the ankle's in plantar flexion. What is now activated? Okay, I have glute max at the hip, I have rectus femoris at the knee, and I have my plantar flexors, my posterior tibial gastroc activated at the ankle. Those are the ways that you can break this information down. The key with Gait is to make Gait very repetitive, and you're going over the same information using the same verbiage each time. Because as you do that, then you start to really understand and grasp the concepts. This will be, or this will make more sense when we begin to review um, questions with Gait, because then you'll be able to see, okay, well, this question is specifically asking me about heel off or terminal stance. So I know what is supposed to be active. I know glute max, rectus femoris, posterior tib, gastric are supposed to be active. So therefore, I can effectively answer this question because I know what's supposed to be active. So I know that if there's an opposition in terms of primary deficit, then I can be able to name that effectively. Again, this will all come together when we start to look at the actual questions, but this is the good foundational information for that. You then have toe off and pre-swing. So again, this is still within the stance phase. This is the time that your great toe extensors or your extensor hallus longus is activated. So another key thing that I think that you would currently do is that if there's a special muscle that is not necessarily named other times, then I bring that out in that phase. So, for example, in mid stance, I brought out explicitly glute medius is active, right? And heel off, I brought up that glute maximus is active. And toe off, I'm talking about the great toe extensor, extensor hallus as long as it's a special toe that is activated. So being able to speak to if there is a muscle that is active that is not normal, then that's imperative as well. Okay? So moving towards your traditional versus your ranchos, there's the Migos language for swing phase. You have acceleration, which equals mid swing, or excuse me, initial swing. Mid swing equals mid swing, and deceleration equals terminal swing. What I want you to pay attention to is that a lot of the ranchos language talks about basically the body in relation to the extremity, right? So, however you able to remember this information, then it is up to you in terms of these definitions. But I would say to go as to even so far as if you printed this information out, you print out that the gait cycle that I presented at the beginning. You actually put the picture of each one of these with the definition so that you can have that visual aid along with the actual definition right next to it. Okay? Um, so again, acceleration, initial swing, we're trying to make the extremity as short as possible. So we're in hip flexion, knee flexion, and we're in dorsiflexion of the ankle. Okay. Same thing when we move to mid swing. The only difference is that now the actual extremity is right underneath the body, right? And so again, we're in hip flexion, knee flexion, and dorsiflexion at the actual ankle, right? So nothing abnormal or any extra muscles that are activated during this time. And then during the deceleration phase, terminal swing, right, which is basically meaning we're coming to the end of the swing phase, we're starting to have um, still have knee flexion. Excuse me, misspoke. We still have hip flexion, but we're moving into knee extension at this point, and now we're ankle dorsiflexion. Okay. So that's the definitions of those pictures that we saw. Okay. So again, in review, you want to look at the actual how you pick up your study, and would be I want you to print out a page of that actual picture that I reviewed at the beginning, and then you're going to compare that to your notes that you are have here, and so you're going to cross reference the picture of the gait cycle. You will have written down what's occurring at each phase of the gait, which we're about to review right now. Um, and then you'll also cross reference that to the information in terms of the actual terminology that's presented here as well. Okay. Um, so some actions of the muscles of the lower extremity that are activated. You have your rectus spinae, extension of the hip, glute max, extension of the hip, glute med, leveling of the pelvis, hip abduction, iliopsoas, hip flexion, adductor magnus, a deduction of the hip, quadricep femoris, flexion of the hip, extension of the knee, and hamstrings is going to be extension of the hip and flexion of the knee. Okay. Moving on down, you have your gastroc, right, which is going to do extension of the knee, plantar flexor of the tibia, or excuse me, plantar flexion of the foot. You're most often going to be looking at plantar flexion for the gastroc. Is what's going to be the prime mover. You have your tibialis anterior extensor hallucis longus, extensor digitorum longus. So your tibialis anterior is going to be doing dorsiflexion, um, and then and as well as that should say eversion of the foot, and then obviously your extensor hallucis longus, extensor digitorum longus are both going to be working to do extension of the actual toe. Tibialis posterior is going to be working on plantar flexion and inversion of the foot. And then your flexor hallucis longus, flexor digitorum longus are contribute as well, but they're also their prime movers are going to be flexion of the toes. Typically, they don't mention too much of your flexor hallucis longus, flexor digitorum longus. Peroneals are going to perform eversion of the foot. In terms of these are again repetition of the muscles that we previously discussed in the lecture before. Um, so this should be a review at this point, right? What I do want you to pay attention to is outside of erector spinae, all the other muscles, you want to know what's their innervation. So what is their nerve innervation? Because, for example, they could say that the individual has a deep peroneal nerve injury. What is a likely gait deficit? Well, then I have to know, okay, deep peroneal nerve, what does they innervate? Deep peroneal nerve innervates tibialis anterior. So if they have a tibialis anterior weakness, then they then have lack of dorsiflexion. So that is how how they could present some of the gait questions. They can not only talk about the gait cycle, what's happening, they could talk about the muscle and then ask you to relate that to an action. They could talk about a nerve and ask you to relate that to a muscle action. So be prepared to be able to speak to things robustly. But again, that is information that we covered in the previous lecture. This is just at this point being more repetitive with the information. Okay. So obviously, this is within the presentation. This is a chart that breaks down what is happening at each one of the joints, hip, knee, ankle, foot. Um, I talked about this with the gait cycle. I found that looking at the gait cycle and speaking to this as opposed to this chart, although helpful, actually looking at an actual gait cycle, because that kinesthetic learning that students have is being enacted is more, has longer carryover than just looking at this chart. So a couple of things that I want to point out, I won't review it or read it to you, is that when it has an arrow down, that means that muscle is starting to deactivate, right? If it has a check mark next to it, that is indicating flexion. Okay. Another common question is, let's say for heel strike at the hip, it says glute max, hams, erector spina, eccentric. Whenever it says eccentric is going to, or concentric, it means the muscle that is directly in front of it. It's not meaning all of these muscles. Okay. All right. Again, review this chart, but to simplify it, the simple way is going to be looking at your gait cycle and actually reviewing that information as such. Again, this is still in there because students still like to have it, but again, you do not need to know the actual amount of dorsiflexion, knee flexion that's occurring during this gait cycle. Okay. This then goes on to talk about the muscles that are activated during the swing phase. Again, you will see some of the, again, repetitive muscles. If you see a check, again, that means flexors. The eccentric concentric is going to be about the muscle that is immediately in front of that word. Okay. And we see that, again, build up along knowledge base. In the previous lecture, when we talked about the musculoskeletal comprehensive information, we talked about isometric, isotonic, isokinetic, concentric, eccentric. So all of these terms are kind of consolidated at this point, so that when you're reading this information, it should now just flow easily. And so you're able to concentrate more on the actual content of gait as opposed to having to look up, what does this muscle do? What is this muscle action? What is this muscle innervation? What do these words actually mean? You should now just be able to concentrate on the gait that is in front of you. Okay. So some miscellaneous information that can be helpful that you may see within the context of NPTE questions, right? And so knowing that essentially these words, when grouped together, have the same meaning. So femoral anteversion is essentially medial rotation of the femur. You can also see toe in. Okay, femoral retroversion is lateral rotation of the femur, and this can also be associated with toe out. Internal tibial rotation, or excuse me, torsion, it's going to be medial rotation of the, that should actually say tibia, as well as external tibial torsion should say lateral rotation of the tibia. Genu valgum is internal tibial rotation, knock knees. Genu varum is external tibial torsion, bow legs. So I put this in there so if you see these words, these phrases within questions, then you have a good framework of they essentially mean all the same things, right? They mean, if you see external tibial torsion, that means that the tibia is rotated laterally, which is going to, when it says toe in or toe out, I know that some people, they're talking about essentially where's the great toe pointed. So essentially, in a normal gait pattern, the toe should be going right and forward. It should be going in line with the muscle, with the extremity, which should be one in front of the other. When you have toe out, your toes are pointed laterally, so they're pointed away from your body, right? When you have toe in, that means your toes are pointed towards your body, but almost like your toes can kiss. Okay. So now we're gonna discuss abnormal gait. Okay. So if we are looking at abnormal gait, there are some key characteristics that we're going to review that will assist you in being able to understand this information a little bit better. But again, this is information that we previously have reviewed, right? Reviewed in the respect of we have looked at these concepts in relation to each other when we previously discussed the actual what is supposed to be occurring or what could be occurring during the gait cycle. So we look at antalgic gait. Antalgic gait is essentially painful gait. So again, if we think about things that we talked about previously, we talked about in individuals who have avascular necrosis, they typically have an antalgic gait pattern, right? So typically, antalgic gait is going to be due to individuals protecting their extremity because they have pain. Okay, what this is going to lead to is a shortened stride length, um, and then it's going to lean a shortened stride length on the actual side that the impairment is occurring on, and there's going to be a longer stride length on the side that is not impaired. The example here is that the individual has left knee pain. They're going to have, and so the stance phase of the left lower extremity is short. So remember we talked about stride length, right, is when we're talking about one side. So I'm just talking about my left side. So basically the distance between when I put my heel down the first time in initial contact to when I put my heel down the next time initial contact, that distance will be shortened. And we think about theoretically why. In antalgic gait, right, I'm typically going to have a shortened length on the side that I'm having pain because I don't want to put a lot of pressure through that side. So again, let's maybe think about somebody who had a total hip replacement. They're typically going to, be weight bearing if tolerated after they their surgery. So those individuals typically put their walker down, and let's say I had a total hip replacement on my left, quickly put that left foot down, and then want to get off of it really fast, right? So it's because of the pain. Is basically you want to decrease the amount of time that you're weight bearing on that side. Yeah. You have ataxic gait. So when we talk about ataxic gait, we'll talk about more about this in our neurological um, section. But ataxic gait is basically uncoordinated gait. It's typically going to be due to a neurological deficit. And so the example that I give is your ataxic or sensory ataxia slap. And so basically what happens during the stance phase, specifically initial contact, the individual has uncoordination of the anterior tibialis, and so that they don't have control to slowly lower the foot, actually slaps the floor. Ataxia can occur basically in any muscle, in any joint. I just use the example of dorsiflexion because it's typically illustrated easier. You can have ataxia in the hip, ataxia in the knee, ataxia in the entire extremity. So it's just not going to be an ankle, to be anywhere along the chain, but just for a good example, I just utilize the anterior tib, maybe one that is affected. Equinus gait, again, when we talk more in your neurological section, we'll talk about this a little more, especially with your cerebral palsy population. So knowing that Equinus gait is essentially toe walking. Typically, if it's bilateral, that's when it's in the CP population. Unilateral is your non-cerebral palsy population. And so typically, if it is unilateral, it's because of a contraction, meaning that your ankle is in plantar flexion, stuck in plantar flexion, which will essentially cause a leg width discrepancy. And so if when we talked about earlier during the swing phase, essentially to be able to get through swing phase, I need to make my leg as short as possible. If I am stuck in plantar flexion, my toes are always in contact with the floor. Essentially, I have to compensate, right, up the chain. So this can lead to circumduction. So we talked about like the surrounding of the hip going in a circle, right? So circumduction to be able to clear that leg. Or it may be some hopping mechanism that's going to be associated with it. Whatever it is you need to basically be able to clear that leg effectively because you're stuck in it to that plantar flexion. Okay? glute medius or Trendelenburg gait. Okay, so glute medius, as we talked about, is only activated during mid stance, right? And its goal is to keep the pelvis level. So if I am in stance phase on my left lower extremity, excuse me, mid stance, then my left glute med is going to be activated to actually try to keep my pelvis level. If my left glute med is weak, what's going to happen is I'm going to have increased lateral lean over the affected side. So I'm going to lateral lean to the left. My hip is going to drop on the right, and then I'm going to have a hip hike on the left. Okay. So again, I have left glute med weakness. I'm going to lateral lean over the left. That hip is going to drop on the left. Excuse me, that hip is going to hike on the left and then drop on the right. So again, that pelvis is going to be unlevel. One more time, saying it correctly. So left glute med weakness, lateral lean to the left. I'm going to hike on the left and then drop on the right. Some common exercises that you could do to essentially assist with decreasing or working to improve glute med is going to be one you could do in close chain would be functional activities, so going up and down stairs would be one, and then if you're doing open chain, then your clamshell exercise is a good one as well. Your hemiplegic or hemiparetic, again, we'll talk about this more when we get to the neurological section, but just knowing that this essentially is weakness or flaccidity in one of the lower extremities. There can be a wide range of deficits that could be occurring because you could have weak hip flexors, which means essentially during the majority of the gait, I have to do compensatory movements. I could have weak hamstrings, weak rectus femoris, gastroc. So you could have multiple deficits that could present. You could have multiple questions about CVA, how that's presented um, with um, with hemiparetic gait, because you can say anything down the chain in the lower extremity could be impaired at that point. Step or drop foot gait. This essentially is when the individual has a weak or paralyzed dorsiflexor, so they have foot drop, right? So we talked about how dorsiflexion is imperative in initial contact, loading response, through all the phases of swing, we need dorsiflexion. So if I don't have dorsiflexion during initial contact, loading response, right, my foot is just going to hit the floor. It's going to be a foot slap, okay? If I don't have it during the swing phase, my foot is going to be in plantar flexion. I'm not going to be able to clear that leg, so I'm going to have to do some type of circumduction in terms of compensatory strategy, right? So just knowing that this information, um, thinking about how we are building upon information, right? So we're not only just talking about the muscle that is weak, but now we're trying to see some of the deficits. Again, this will make more sense when we try to look at questions as a whole rather than looking at this information in silo. But I do want to present it to you so you have it, and then therefore you can read through it and dissect through the concept and make sure you have a good understanding. Scissoring gait. Scissoring gait is typically going to be caused by adductor spasticity. Again, we touched on spasticity management on medications when we talked about the musculoskeletal medications. But knowing that adductor or scissoring gait typically is going to happen in individuals who have maybe cerebral palsy, who have an upper motor neuron lesion, so a CVA, a spinal cord injury, TBI, this can be affected. So basically, this makes where the basic support is very narrow, and the individual is going to not be able to have that normal flexion of the hip, knee, ankle as they would because their legs are so close together. Okay? Right? And those are the references. So questions in terms of how to break this information down. Again, I would say start out with the gait cycle, writing down what's happening at each phase of gait. You don't need these notes to be able to see the hip flexions occurring, knee flexion, ankle dorsiflexion, right? You can then go and start the beginning of the lecture, where the beginning of the lecture really is definition based, talk about step length, stride width, cadence, that part. So that may take you one day. The next day, you may look at the actual ranchos, versus the traditional language, and then compare that to your chart to say, okay, I now see in the gait cycle, this is what's happening, and this is what the words actually mean for initial contact. This is what the words actually mean for pre-swing. Okay. Um, you can combine that information with the chart that has like the kinematics information. So that chart that's here, that's starting to look at some of this kinematics information, just to make sure that the chart that you created on day one in terms of gait cycle is accurate. Um, the next day, you may want to look at the miscellaneous information and then start to look at some of the gait deficits. Again, the gait deficits along with the normal pathology will make more sense once we actually see what is supposed to be occurring during the normal times of gait, or excuse me, once we start looking at actual questions. Okay, so this is the gait lecture. The next step after this is that we will then look at prosthetics and how prosthetics can contribute to gait deficit, right? And then lastly, we'll review questions, right? Hope that this was helpful. Um, Let me know your feedback, comments, and have a good one.